changing availability of common methods of suicide can have a big effect on suicide rates. And it's undoubtedly true. I've seen so many people who've been in absolute depths of despair and have seen how things can shift and they come out of it.
So I guess I'm super keen for you to hopefully tell us that, yes, there are things that help, and there are things we can do to prevent deaths from suicide.
Yeah, I mean, I think there definitely are things one can do to prevent suicide. But it is important to acknowledge that one isn't going to be able to prevent all suicides. Indeed, one could argue that it may not be desirable to prevent all suicides. I mean, suicide, is an option that a lot of people would like to have if under certain circumstances. But having said that, a very large number of suicides can definitely be prevented.
Yeah, you told me that the first time we met, and I was kind of shocked by that. But then I guess, is that referring more to euthanasia, or even if there's someone who's, caused so much damage in humanity, like someone who's, some like terrorist or someone who's like...
Well, I wasn't thinking of that. I was thinking, more for people where I suppose, assisted dying, if you like, that sort of concept, which of course is gathering momentum. There's a big shift in views about assisted suicide in many countries, and certainly happening in the UK. And I think it reflects partly the growing age of the population, more people facing infirmity, severe handicaps, where quality of life is really zero for many of them, and that. But I wouldn't want that to be seen as undermining attempts to prevent suicide in the population at large. I think everyone's talking here about specific issues, end of life issues. But I think it's really important to keep a focus on prevention.
Yeah, and that's mainly what we'll be talking about, which is like young people or people suffering from depression, or nurses, or after divorce, or...
Sure.
So before we get into that, let's talk about how you grew up and your background briefly. So, well, I guess first, by way of introduction, you are a professor of psychiatry at the University of Oxford, where we are now, and you're also a consultant psychiatrist. Mm-hmm. So do you mind briefly explaining what those two roles entail?
Well, as a consultant psychiatrist, it is and was for me very much about running a clinical service for people with mental health problems. In my case, it was adults with mental health problems, the whole range of mental health issues. Running a service which included inpatients, quite a large inpatient service, outpatients, and community outreach. I'm talking about it historically because I stopped working clinically quite a few years ago, having done 30 or more years of clinical work. Alongside that, I was always involved in research work of various kinds, in beginning with work on self-harm, attempted suicide, and then embracing suicide and suicide prevention. and a whole range of studies over many, many years, which I'm still doing. And that the academic side involved obviously designing projects, coming up with ideas, designing projects with other people, seeking funding, which is the big challenge, as you probably know, and increasingly difficult to get the sort of level of funding that one needs for most studies. And then obviously designing the studies, carrying them out, writing up the results, and bringing along young researchers, which I've always regarded as, absolutely crucial. And, I like to think there's quite a few people out there now who have, some of them become professors themselves, who I've sort of helped along the way. With getting into research academia and hopefully becoming successful. So it was combining that clinical work with doing research. Much of my research has been clinically orientated, and I've always thought that it's really advantageous to be both a clinician and a researcher to ensure you do relevant research rather than going off and maybe looking at things that might be really interesting but actually not very helpful for people or the population.
And you're staying in touch with the people who are actually suffering with these
Exactly,
things.
yeah.
Okay, so what was your path to getting here, starting with how you grew up?
Gosh, how I grew up, I guess a pretty ordinary background. Father worked, mother didn't really. I went to a grammar school, which I thought was really good, co-educational, which I'm really grateful for. I think it really does help to have the genders or sexes mixed at from an early stage. And very into sport, still am. All sorts of sports, particularly athletics, cricket, and a lot of cross-country running and all this sort of thing. Right, and then later rugby. And also from an early stage into music of a more popular kind, which I still enjoy going to gigs when I get the opportunity. And was fortunate to be in a really bright class at school, which helped, I think, provide a stimulus for me to do better. And we were quite competitive, a group of us. And I was lucky enough to get a place at Cambridge and spent 4 very happy years there, which I'm eternally grateful for. And then I can tell you a bit more about how that worked out. But in general, that was just a great experience. Not just the academic side. I mean, in fact, I would say the social learning side was at least as important for me. And, developing an ability, hopefully, to get on with all sorts of people and some people from social strata that was unfamiliar to me at the time. And I think that was, I'm just so grateful for that experience.
And where was it that you grew up?
In, what is now North London. It was on the edge of London. So we were living just on the edge of London. When I went to university, my parents then moved down to the south coast near Brighton while I was at university. So I had some upbringing in that area, but mostly it was in what would now be North London.
Like around Hampstead or something? Or
No, this is further out, Barnet area.
Okay.
Yeah.
Nice.
Mm.
I guess Hampstead joined London like 200 years ago.
Yes.
So, and was there any expectation on what you should do after school, or were you...
No, I mean, my parents really didn't have put any pressure on me. I mean, my going to Cambridge, I was the first in my family to go to university. And the fact, my parents were incredibly proud of the fact that I did, and especially that, went to Cambridge. But there wasn't any pressure. And it was almost, I remember once I failed an exam, and my father said he thought it was a good thing for me to have a failure experience, and I was furious. There wasn't pressure at all.
It was more you putting pressure on yourself.
And obviously, having a peer group who were achieving helped a lot.
Huh. Mm. Okay, so it was a massive sense of achievement for you getting into Cambridge. Mm. And what do you mean by different social stratas? Because I understood it's only now that they're really pushing bringing people from, all different demographics, whereas...
I suppose predominantly then, the majority of students at Oxbridge would have been from public school backgrounds, so very different to the grammar school I went to. And, would come with perhaps a lot more social skills or graces, one might say, than some of us had from different backgrounds. So
back in the dining hall.
Yeah, back in the day. And I found that okay. Some people found it quite challenging and difficult, but I sort of embraced that. I feel I'm a person that's tended to get on with people from a lot of different backgrounds. Mm-hmm. And maybe that's partly, because of the experiences I had school-wise and around where I lived, and then the, exposure to a whole range of other people at university.
Okay, wow. So it was rare to even have grammar school people back then, let alone...
It wasn't rare exactly, but it was very much the minority.
Huh.
Yeah.
And then state schools you wouldn't have, or not, because grammar schools are a type of state school.
State school, yeah.
But you have to do an exam to get in, right?
Yeah. What they call the 11 plus, they used to call the 11 plus exam, yeah.
So people who are just from ordinary state schools, they would have been even more rare.
Well, that would be what then became, because the whole school system changed with this move to comprehensive, to try and embrace, rather than having this split system of grammar schools and then other secondary schools where people went who hadn't got through this 11 plus exam. There was a move to making schools more what they call comprehensive, so it embraced a wider range of the population, which is probably a good thing, but yeah.
Okay, and then so you were just telling me while you're at Cambridge you were doing science, you thought maybe zoology, and then you became interested in psychology.
Yeah, we had. I was lucky enough. We. I think you're familiar. I think reasonably familiar with the natural sciences, way things work, natural sciences wise in Cambridge, and I was able to do experimental psychology as a what they called half subject in those days, and loved it. And so then did my final undergrad year in experimental psychology, and it just happened that there was a group of absolutely top-class psychologists, British psychologists, in Cambridge at the time, and it was absolutely inspiring. And I think, one of the things it helped me with was learning experimental techniques that I could use later on in my career. And I wanted to go down the route of psychology. I was going to go and do a DPhil in psychology in America. And it then happened that we had some lectures from some charismatic psychiatrists in Cambridge. And I just thought, gosh, this is such an interesting subject. And, they were very naive days. I just decided, right, I'm going to do psychiatry. Little knowing that I had to do medicine to do that. And at any rate, it resulted in me having an extra year in Cambridge doing anatomy with the medics. And fortunately, I'd already done physiology as part of the undergraduate work. So, and then moving over and doing clinical training in medicine, coming to Oxford, where I've been more or less since, and doing psychiatry training here after doing house jobs, as they were called in those days.
And what interests you most about psychology in those very early days?
I think one of the things was, whether I thought it very consciously then or not, but on reflection, it was this challenge and ability to measure human emotions. I think it was fascinating. And, the fact you could, for example, try and measure how depressed people were, and measure symptoms and so on, and look at changes in that. And, I think that was one aspect. Maybe it's through, reflection I'm saying that, because it really did influence my clinical practice, which I've been and was a great believer in measurement of people's levels of depression, anxiety, whatever, and looking at how things change with treatments and so on. So I think that because it was experimental psychology, and I think that had quite a big influence, and on my research, obviously. And
were you very aware of depression or anxiety at that point in your life?
Not really. No. I mean, one was aware that some students had problems. I don't think... it's very difficult to know, looking back through the lens of years and years of working with people with mental health problems, what one thought at that time. But
it wasn't in your family growing up? Or anything
no, there was no particular experience.
And you didn't have any personal experience or anything?
No, I had a college. My first year, I was living out of college in a house, and one of the other student who lived there had some serious mental health problems. I never quite found out what they were, but I was aware that he was really quite seriously ill, and eventually, he unfortunately had to leave. But I wouldn't say then I was particularly aware.
So you were really just interested in the ideas?
Yeah.
And then how did you get through medicine having that focus on psychiatry? Because I think first of all, a lot of people don't know the difference between a psychologist and a psychiatrist. So a psychiatrist, of course, is a medical doctor, and so therefore can prescribe medication, and whereas a psychologist is not. But I think I even had that at school, like, I'm going to be a psychiatrist, and then it was like, yeah, you have to do medicine. It was like, okay, no, I don't want to deal with dead bodies and blood and stuff. So were you interested in that side, like the biology side and all?
Well, I had been interested in doing zoology originally, so I have quite a big interest, obviously, in the biology angle. I didn't like anatomy, to be honest, and I was fortunate in my final year in Cambridge, and I had to do anatomy, that I had an American co-student who did most of the dissection and stuff, and I was probably off playing cricket or whatever, and so that worked out okay. And for example, I didn't enjoy surgery when I started doing clinical medicine, medical training particularly. Obviously I had to do a house job in surgery in those days, and I did one in neurosurgery, which I found really interesting, and helped me learn quite a bit of neurology and so on. But I did that side of medicine I was less keen on than the more, I suppose, I was going to use the word human side, but that's not very fair on surgical colleagues and so on. But if you know what I mean, I was more interested in the relationship with patients and I guess the emotion, But it wasn't testing, but it was interesting because I knew right from the start I was doing medicine in order to do psychiatry. I never deviated from that. But I was also, playing rugby, playing a lot of sports, and my co-students would sort of find this a bit of a somehow contradictory, that someone who was very much a sporting sort of person was also ending up in psychiatry. It was to do with, traditional ideas of psychiatry being for people who are a bit peculiar and so on. And hopefully...
Really?
I think I didn't quite fit the peculiar mould.
Peculiar in what way?
Well, interested in quirky things, and which I am interested in quirky things, but I suppose I would have been regarded as someone who wasn't that sort of deep in terms of thinking about people's emotions and so on. Yeah, I think I was. But I think superficially I came across as, someone who was out to have a lot of fun and, play sports and all that sort of thing, and which didn't quite fit in with the view that psychiatrists spending their whole time dwelling on problems and so on and so forth.
Mm. And so when you got through those medicine years and started practicing psychiatry, were you like, yes, this is exactly what I wanted to do? And
by and large, yes. Yeah. And I always found it interesting. I think the point I made earlier about, developing an ability to relate to all sorts of people was helpful. Not just patients, but also staff. I generally have had very good, I think, well, I hope I have, had good relationships with other clinical staff, nursing staff, medical colleagues, etc., psychologists and so on. Mm-hmm. And I think having had a background in psychology also helped.
And then how did you end up focusing on suicide and self-harm?
Well, that's very interesting, and serendipity, I guess. I had a boss, a really influential boss at the time, a consultant psychiatrist, academic psychiatrist, who at the end of my training said, Keith, I've got this job for 2 years to set up an intervention study into people who were self-harming or attempting suicide, which was a growing problem at that time, and people were becoming more aware of it. And he said, would you like to do it? And would you like to take on this, fellowship for a couple of years? And I thought, well, I'll do this for a couple of years, then I'll go and do something else. Of course, I did do other things, but I've never actually left the field of self-harm and suicide since.
Because what are the other types of things you can do within psychiatry? Is it like looking at schizophrenia or other types of...
Yeah, I mean, sure, but I tended to have a particular interest in general hospital psychiatry. So we did some work, for example, on chronic fatigue syndrome back in the days when, people were becoming more aware of it. We ran the first clinical trial of a psychological intervention into that problem. We did some work on neurological problems and how they related to psychiatry, particularly with a focus on people who'd had strokes and how that affected their mental health. And I also, again, influenced by my boss, who became a very eminent sexologist. In fact, he eventually ended up running the Kinsey Institute in the USA, the main sexology research institute. I developed a whole program of work, initially under his guidance, and subsequently after he moved away, I carried this on independently with people who've got sexual problems of various kinds, and ran a sexual dysfunction clinic. Trained a lot of people in treating, helping people with sexual dysfunctions and so on. Wrote a book on that topic once. Now it's feels a bit historical in that I haven't been in that area for a good long while. But so I did do there are a range of other things I got involved in. Mm-hmm. I think one of the things that's so fascinating about psychiatry is that it embraces so many aspects of human life, and it's not just about schizophrenia and depression and so on, but other aspects of life. My wife, who's sadly no longer alive, she was an excellent clinical psychologist, and so I had the influence of her, expertise in clinical psychology. And although our children used to complain that, at the dinner table we were talking psychiatry and psychology all the time. I remember one of them saying one day, "Why do you keep talking about psychiatry and psychology?" And we both found it so fascinating. But we realised that perhaps we were focusing a bit too much on our work.
Got it. Okay, so when you say it was suicide or self-harm, was people becoming more aware of it, or it was growing at that time? Do you think, was it actually growing, or it was more just because it's all the issues with stigma?
Well, no, it's fascinating looking back, because at that time, there wasn't a lot of focus on suicide prevention. I think, suicide was sort of accepted as a sad fact, but there really wasn't much emphasis on it. However, what was happening was that increasing numbers of people were presenting to general hospitals, not just in this country, but in many other countries in the world, following various forms of self-harm, particularly overdoses. And it was a growing problem that clinicians in the general hospitals were having to deal with, the physical side of it. But there had been little provision for the mental health care of people who were presenting with self-harm. And here in Oxford, we became really, probably the leading centre. And I think I would accredit that partly to my former boss, who started to develop a service. But he was a great believer in not just going in and doing what seemed the right thing, but researching the problem and then developing the service alongside the findings of the research. And I was lucky enough to be in at the beginning of that. And that area, I guess, has been my main area of work throughout since then, particularly focused on self-harm, how to the sort of problems that lead to self-harm, how the problem has developed, so sort of epidemiology, if you like, of the problem, of interventions, testing out interventions, evaluating interventions, and obviously, major concern about the relationship between self-harm and suicide. So my sort of focus on suicide prevention sort of developed a bit later, and I guess it was at a time when people were starting to pay more attention to prevention of suicides. And certainly, I mean, the size of the problem of the numbers or the rates of suicide were actually quite a lot higher then than they are now. But now there's much more interest in the problem and doing something about it.
Yeah. Well, because they're still really high now, right? It's like isn't it the biggest killer of men under 45?
Yeah, that's true. Yeah. I mean, it's long been a problem in that group. Of course, other causes of death have become less common, which is partly why, it's sort of risen to the top of, and suicide has proved much less easy to tackle than other common causes of death, like
accidents.
Smoking-related problems, car accidents. Yeah, exactly.
But why do you think it's come down over time?
Well, I mean, we had one remarkable thing happen in this country, was that, I mean, I don't know how much you want me to avoid talking about methods of suicide in this discussion, but there was a particular
Actually, that's
method.
what I wanted to ask you about. You're going to talk about the town gas point. Yeah, no, I think that's really interesting to talk about. But before we do, on methods, because sometimes, I've had people on this podcast come and just talk about being suicidal, and then someone's described like which was to do with overdosing, and so I was kind of like, oh, is this okay to share or not? Because I understand that it's with the methods, when people don't know, it's like taking away access. And then I figured with overdose, because like it didn't work, and then also you're just talking in general, you're not like naming drugs, like maybe that was fine, but how does
well, I think, and a point to make, to anybody who's listening to this, that I suppose, this is a sort of a bit of a trigger warning, if one does mention methods of suicidal self-harm, it can set up thoughts in people's minds about those particular methods, particularly if they didn't know about them before. And I think, we would generally avoid talking about very specific and new methods and so on, because of concerns that one can cause, people to seek out such methods who maybe, I think, feeling hopeless at the time and so on. I think it's, but I think nonetheless, historically, it's important to make the point that changing availability of common methods of suicide can have a big effect on suicide rates. And it's undoubtedly true.
Yeah.
I mean, this is why, one wants safety barriers on bridges, for example, that places that have become
Yeah, and so people can, because that's an issue, right? I know with, I was reading one case about the barriers on a bridge, and people are saying, why should we invest in this attitude that if someone's going to suicide, they're going to no matter what. And this study shows like that's not true, and they talk to people who were at that point and then were talked down from it or whatever, and those people go on to not ever suicide.
It's a remarkable fact, but it's true. It doesn't mean everybody won't, nobody will go on to try and other methods, but a lot of people won't. And one of the other things is that where people have been interviewed following very serious suicide attempts, such as, jumping from a bridge and survive, and I think this is a really important message, and the predominant thought they have is of survival when they've actually started the act. And it's a sad fact. And I remember interviewing a young man in the USA in a hospital there who badly injured his legs and so on from jumping from a high bridge onto a river, and he got himself psychologically trapped into carrying out the act. And but he talked about his first thought was survival, and of course when he hit the water, although he damaged himself, he swam to the side and was able to survive it. Now, for me, that was such a powerful message, that these thoughts aren't there, that you're thinking, I want to die, I'm going to do it, and that those thoughts persist until the end. And it's a sad fact, of course.
Yeah.
But just going back, I suppose one ought to mention the big impact that we were touching on here in the UK, which was when we went over from toxic domestic coal gas in the domestic gas supplies, and this is when people had gas ovens, cookers, were mainly gas in those days. This is back in the 50s, and before, but going through to the early 1970s. And then we switched over to non-toxic North Sea gas gradually. And it was an extraordinary natural experiment, if you like. The suicide rate just steadily dropped, and it dropped by a third. It was just absolutely remarkable. And one's seen similar examples for example, in lower middle income countries, where particular methods that are being commonly used have become less available. There's been a big population effect on the population rates of suicide. And that's one really important message about suicide prevention, that is one way in which one can influence suicide rates.
Yeah, and of course there's that's part of the whole gun debate with the US. And you see those numbers. So it's like, you just have to look at the data. But yeah, so because with the town gas, I think Malcolm Gladwell writes about this, and Sylvia Plath's a famous example, and he was making the point that it was a means used by a lot of women because someone else was explaining to me that men, because the suicide rates are much higher in men, right? It's like, is it like 7 to 1?
No, 3 to 1 in
in
this country. I mean, it does differ in other countries, but.
And even though depression and anxiety are more prevalent in women, right? So someone was explaining that it's more like men tend towards more violent means, whereas women, this was like a non-violent means.
Yeah.
And then because that became less available, it was like particularly in women you saw the rates.
Yeah. Yeah, it affected both genders, but there was a very marked effect on suicide in females. That's true. Mm-hmm. So that and there's as I was saying, other examples of these big effects of changing, making a commonly used method less available. So that's one principle of suicide prevention. And it applies to all sorts of things like availability of medicines, trying to use medicines which are less toxic than others, such that if someone decides to take an overdose of medicines, then they're less likely to die from that.
And are there other obvious things we can do now, like that can be done in this country, like barriers?
Yes, yeah, indeed. I mean, there certainly are, and across, I mean, they often getting something like a barrier on a bridge, which has become more well known for suicide. Encounters major challenges, and they're often about what it's going to look like having a barrier and so on, and those can be a huge challenge getting barriers. I mean, this happened with a particular bridge that was quite popular in this country. And eventually a barrier was put up, and sure enough, the suicides from that bridge obviously declined. But importantly, it wasn't that people went to other bridges in that particular city, and so it had an absolute effect on suicides.
Mm-hmm. And what about rules around, like, if we know showing the methodologies is a bad thing, could we just make better rules around what can be shown on TV? And because isn't it like that?
Well, we have it's not so much rules but guidance for the media. I mean, we have, for example, in this country, Samaritans produced media guidelines. I was involved with that right at the beginning when they were doing this years ago now. And they've gone through several versions and so on. And it's had a really good effect on the way suicide is reported in the media. So, we've done some work showing this. So over the last, 12, 15 years, there's been a remarkable improvement in the way suicide is reported in the media. Partly because of this avoidance of reduction in mention of specific methods, and partly because there is usually links to helping agencies at the end of articles, and so that switch has been quite remarkable and I think really positive. And the media, most media outlets, and newspapers, TV, portrayal where suicides are portrayed in dramas, they will take advice or follow guidance in terms of what's produced. There are exceptions, sadly, but generally that has greatly improved. So that's been another important sort of element in the suicide prevention program.
Yeah. And we know that does help.
There's reasonable evidence. It's less easy to show that that helps, but there has been some examples. I mean, one example, recent one in the States, and this was more about promoting a helping agency. So this was in a rap song where the telephone number of the main helpline in the US for suicide prevention was included, and it led to a massive increase in people using that helpline and some short-term reduction in national suicide rates.
Wow.
I mean, this is a very recent study. So that's, that's a powerful example of, how positive messaging can be helpful.
Yeah. So for this podcast, whenever there's talk about self-harm or mental health or suicide, I always post those links at the bottom, like the crisis text line and Samaritans. Is that kind of sufficient, do you think? As well as saying, you said, well, it's clearly in the title, this is what we're going to be talking about.
Well, I mean, I think, I think it is helpful. Whether it's sufficient, I think the other important thing to get over is the fact that, talking to people about one's bad feelings and thoughts can be enormously helpful. And, generally, gross generalization, but women are better at this than men. But I do, and I particularly like to get that message over to men, talking to others, to mates, to, helping agencies, of very voluntary agencies and so on, that talking about one's feelings can be really helpful. And it's a sort of simple message, but it's quite difficult to get people to accept that's the case. And often the reticence is tied up with sense of embarrassment. People are not going to hear about my problems, or I might even be laughed at, and all these sort of feelings. But by and large, and I think things are gradually improving because this message is put out so often, and I do think people are tending to seek help more. We know they are, but that men are, seeking help a bit more than...
Yeah. Well, yeah, because I think there's an enormous shame with having those thoughts. And I think even talking about it to know, it's not uncommon to have those thoughts. And because I've experienced those thoughts and it's terrifying because it's like a moment, it's like panic that you're feeling this and it's like you don't want to be, but it's a fact. So then it's like, but telling someone that, and then that person might not know how to deal with that, and that person then might panic. So I guess that was kind of one of the questions as well from one of my friends was, how can you help someone if they're experiencing these thoughts?
Well, I think, I think the first thing is just showing concern. And even if you don't know how to deal with it in the sense of what you can say that will change those thoughts, just showing warmth, concern, compassion, and is really an important part of this process. Even if you don't feel you've got the skills or knowledge to say things that you think might change things, just being human and warm and comforting.
Like listening.
It's just really, I think it really helps.
Yeah, telling them you're there for them, they can talk to you.
Yeah.
And and that you're there to listen, rather than, maybe that's the panic people get of like, oh my God, I have to solve this. But it's like, no, you don't have to solve it. But if you can just listen.
Yeah. I mean, sometimes people have said to me at conferences, what is the most important element in suicide prevention involving interaction between individuals? And I think it's sort of a no-brainer, really. It is showing concern, compassion, and warmth to someone. It's that for me would be sort of number one. And then other things follow, of course. And if you're seeing a therapist or whatever, then other things. But even with a therapist, it's really important. I mean, in psychiatry, with trainees, sometimes you'd have trainees who would sort of be taking a history from someone, and they'd be telling them maybe about awful feelings and so on. They'd be just sort of writing it all down, but there is another element to that sort of work of just saying, how concerned you are about this and how much you want to try and help the person if you can and so on, and just getting that over rather than having someone just sharing their feelings with a blank, sort of non-responsive automaton.
Yes. Yeah, I think that's so important. The empathy part, and it's like, we're two humans, not like, I guess that's the problem with doctors being so tired and overworked, and it's like, they're just... It
is quite difficult, I think, when you're really tired. You've got your own maybe problems as well, life problems and, family issues, etc., and money worries and so on. And at the same time, you've got to, be in this emotionally responsive mode to people telling you about their life difficulties. But that's what the job's about.
Yeah.
I mean, that's part of what the job's about.
Okay, so another question that someone asked that they wanted to know about suicide is, why do individuals get to the point of such despair that they believe that ending their life is the only option to stop the pain?
Well, I think one thing that often happens when people get very distressed is their thinking gets almost narrowed down to, a focus on the problems and the sense of this can't be solved. I think there's a sort of psychological process that happens that the ability to think about options becomes diminished for whatever reasons, and there's just this focus on the problem, and with it the sense of hopelessness that may come. Why does that happen? It can, of course, be part of depression. I mean, depression has such profound effects on people's thinking, in quite remarkable ways. I mean, I think, when I got into psychiatry early on and was seeing some really depressed patients, their thinking style was almost unbelievable, that, they could just be so focused on the negative aspects of things and seeing no solution, and almost not wanting, well, I'd say not wanting, that sounds inappropriate, but it appeared maybe to someone else that there was no wish to sort of see another option, but it was, I think it was reflecting this constriction of thinking that happens. And I think partly it's the profound effect that the process of depression, which we still don't really understand. I mean, that can have on people's thinking.
Yeah, well, that's definitely what happened to me with depression. It was just like that. That was it. It was like I failed. I was a failure. There was no way out. Like, it was impossible to recover the situation. And it wasn't even like, I guess because your mood's so low, you're not thinking strategically of like, let's map this out. Like, am I definitely a failure? Is there any way to... But it's just like your brain is telling you that, like, constantly. So it's... So what... Yeah, so that was another question that was... which I think links with the depression point, that a lot of people who get to that point believe, and this is what happened to my brother, believe that the world is generally better off without them, like they are a burden. And so they're kind of, hard for me to talk about, but it's like, they feel... And I think, I probably experienced that as well, that it's like, it would be doing the world a favour almost. How many suicides do you think fit in that category versus, I guess, something that's more maybe with the nurses where it's more like you're under so much stress?
Well, I don't know. I mean, I think it can be a feature of many people's thinking who become suicidal. But I couldn't tell you. I think it's a common feature, that sense of being a burden, particularly within families, or having a sense one's a burden on one's friends. And, I might have had the experience of, friends not being responsive to one's circumstance. And, I can certainly think of experiences of people quite close to me have described how their friends, and this is particularly in student days, they got on well with blah, 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 and then for whatever reasons they got depressed and, had all the experiences go with depression, and their friends just couldn't cope with it. And they didn't understand it. And in a sense, they were reacting as if the person was or their feelings were a burden on them. And, I think, having worked with a lot of depressed people with depression, one can understand that, how someone else who's getting on with their life and maybe having a good time, particularly in student days and so on, to have someone who's in a very different position and seems to be focused on themselves all the time and so on, it can feel burdensome to others around them. And that, of course, their response can well make the situation much worse. But at the same time, one can understand it. Particularly young people, who haven't got much experience of this sort of thing, and when they're first exposed to someone who's depressed, it can be scary, and you maybe want to be away from it. It's difficult for you to handle.
So how can we help people in those situations? Or I guess because there was another question here that's, maybe that's slightly different. Are the suicide mental health awareness charities making any difference to suicide rates? But I guess in some ways, is it things like, crisis helplines, but also...
Yeah, and also putting out information about mental health. I think it's got so much better. I think public awareness and public, willingness to talk about suicide. It's still a very scary topic for a lot of people, but I mean, I've been in, as you're aware, in this field for a long while, and the shift has been slow, but now looking back, remarkable in terms of people acknowledging suicide as a problem, being willing. The number of people who will talk about, having a experience of suicide in their families or someone, in their workplace or someone, and so on, is that's just increased remarkably. And I just do think there is a much greater public willingness to talk about suicide, and in both men and both women and men. I mean, it's always been better, and women have been more willing to talk about emotions and suicidal thinking and so on. But I think that shift has been really positive.
And that helps because if we can talk about it, like having this conversation, we can, raising awareness helps because then people become more aware, people are more likely to seek help.
Yeah,
and
I think so.
And also have tools to help others.
Yeah.
Who might be suffering.
Yes, I mean, I think people do get greater awareness of what might be helpful. Simple messages that are put out in the media, about trying to show understanding and some sort of empathy to people who've got difficulties, the fact, that help's available, various kinds. It's not all about mental health services. And, in a sense, I think it's proportionally, less about mental health services than about other agencies providing help. Mental health services, don't get me wrong, are obviously, really important. But the great increase in the volume of voluntary agencies and other agencies, many of which are doing a great job, I think has been hugely advantageous. It's difficult to measure that effect, the effect of these sort of agencies and so on. If you said to me, can you produce evidence that, a particular voluntary agency has prevented suicide, I'd find it very difficult to do. But I do nonetheless believe that these agencies are effective.
Yeah. Well, there was a CEO of a mental health charity, Batir, who came on this podcast, and one way that they measure it is they have people telling their stories to schools. So, years after they've recovered from an addiction or eating disorder or whatever. And they measure it in the students will then say, like, are they more likely to now get help with something that they might be going through, like their parents getting divorced or something going on in the home, and then they can measure it that way, which is really
it's one step. Of course, what people say doesn't always reflect what they actually do, but it is encouraging if people are saying, yes, I would, now seek help or whatever.
And so, I guess that's what I was going to ask on that charity's point, is that a way that volunteer groups and so on can help by providing that extra support, which maybe is almost lost through the community because we have less, community spaces or going to church or whatever. But then that's a way that they can take some of that pressure off, like, the person's immediate friends and family by, doing some kind of group work or...
Yeah, it's an interesting point you make there about the shift in society in terms of where people get their social support from. For example, in this country, we've lost lots of pubs, for example, and I think probably particularly for men, that was a place, that's a place where men tend to go, and get some sort of support, community support. It's not just men, obviously, but I think it's a particular effect in men. And it's been quite interesting that some of the suicide prevention initiatives have been, again, I'm thinking of initiatives for men, have been developing places specifically for men to go and talk about things, not just emotion and so on, but they can talk about all sorts of issues. But like this men's shed development, it's men's sheds or whatever they call it, and where people just get their times when they can go and just meet up with others and have a chat and so on. It's almost though we've now had to replace what was happening through pubs and similar agencies with these other resources, social support resources. But it again just reflects the fact that social support, willingness to talk about issues, not necessarily getting into profound personal stuff, but is really important.
And because that must be one of the biggest factors is isolation. Is that right? So it's like
indeed.
That's where you see it, like men after divorce, because they might have had their partner was their like main social support or who they could speak more. And then that's taken away, and then they're left isolated.
I think that's a very common precipitant of males becoming suicidal. Yeah.
Okay. So, and then what on people who go to this point of feeling suicidal but then manage to turn it around, that was a kind of follow-up question to that first point of why people get to that point of despair. How can people be persuaded that there is a pathway to a better future?
Well, I think, I think, it's often an indirect effect of, for example, having social contact with people. In psychiatric practice now, there's very much a focus on what's called safety planning. And it's sort of a series of levels, if you like, of potential measures that people can take in order, if they start getting into a crisis. And a major part of that is about social contact. It's partly about what you can do yourself to cope with feelings, distraction. What helps distract you from, just thinking of bad thoughts and so on? What can you do? But with a big emphasis on social interaction, be it with just one's friends or specific places you can go in order to get social interaction. So part of psychiatric practice is about having an individual safety planning program for individuals to work out with their clinician, whoever, psychiatrist, psychologist, whoever, what are their sort of strategies at different levels of distress, if you like. And obviously, ultimately there would be, how do you get help from emergency mental health agencies if things get really bad? But a lot of it's about, what can you do to increase your social interactions with people? Because that often takes you away, starts to divert your thinking from this focus on bad thoughts to other things. And that, I'm not sure I've answered your question here, but having the plan, because I guess it's
it sounds weird that it's a distraction, but it's because that thought, it's a moment in time thing, and that's what you were just explaining, that it's a moment in time, and then I guess we're wired for survival, so eventually that it's like you do want to survive, but how do you get, because you were stuck in that distressed moment, so how do you relieve the distress? And it's almost like identifying, okay, when this thought comes, I'm going to call this person, or I'm going to get out of the house and go and get a coffee, and
it's got to be very personal to what's going to work for you, and that you have ownership of that plan, if you like, that it's your personal way of dealing with things. It's not a sort of standard program that's going to suit everyone. It's what you work out with your therapist, clinician, or whatever, is going to suit you, and that you'll actually do. And it needs to be modifiable over time, because circumstances change. You might have a good friend who's no longer available or not easily accessible, or you don't get on with, for whatever reason. And so things change. So it's got to be a flexible plan that is personal to you, which is realistic, and, you're actually going to follow it.
Yeah. And then I guess the idea is, at the same time you're working on, okay, so if you're at the point where you don't, I guess the hopelessness that comes with depression, that's like, I'm stuck in this place and there's no way out. It's like working along, using different things to help the person's access to something that would be a better future. So whether it's finding employment again, or working with a therapist, or
and we have talked about about therapists or so on, but of course one can do this sort of safety planning oneself. So someone out there thinking, well, I don't want to see a therapist, but how can I develop a plan that's going to be helpful for me if things get worse or I go through a bad time? It's something people can do for themselves. It's probably easier when you've got someone who's guiding you a bit and helping you do it, but nonetheless, people can have their own plans that they just formulate themselves, and as long as they're realistic and doable and easily manageable. It's no use having some sort of play, all right, I'll take a special holiday or something. That may not actually be very feasible at the time, and might not be the best way of dealing with things.
Yeah. And so that would have to happen in a moment of when they're feeling good and they're feeling like they do want to overcome this.
Yeah.
And so how do you see, someone else was asking, what is the most, for people who go into these bad places and come out of them, is there common themes of why it managed to turn around?
Well, I think, sometimes, an important factor is often relationships, and it's maybe an opportunity to develop a new relationship that makes a huge shift, but you can't sort of guarantee that for everyone. But that's obviously one element. And I think, it's, as we talked about earlier, it's important to recognise how thinking fluctuates. It fluctuates during the daytime, and there's studies where people have been asked to record their mood and their thoughts and so on over 24 hours, maybe done over several days, but they record them every few hours, and the fluctuation in one's thinking is over that time. We've all had that experience. It can be quite remarkable, and I guess it's sort of one thing is about using the times when you're feeling more positive or less negative or whatever to do this planning. It's probably going to be easier than when you're in when things feel worse. So if that makes sense.
Yeah.
I mean, we all have this experience. You wake up in the morning, you think, this day doesn't. And thoughts crowd in. I've got to do this, got to do that, do the other, and then you have your breakfast and maybe start feeling a bit better and so on. I mean, it's just that's just the normal fluctuation in feelings, and thoughts go along with it. But I guess it's important to make use of a time when you're feeling a bit more positive, rather than just hoping that things will remain that way, thinking, right, what can I do to try and tackle these down phases? What is it I can do? As you said, go and have a coffee or whatever, bit of music or whatever that's going to make a difference and help sustain that sort of more positive sense.
And do you think lifestyle factors can help? That's kind of what I had this depressive period, but when I was hopeful enough that I was like, I'm going to get serious about not trying to not experience this. What can I do? And looked at these factors like obviously sleep and then diet, exercise. There's sunlight exposure early in the morning. There's omega-3, meditation, all these. So I was like, I'm going to slowly add them in. And I don't know if it's how much of it's almost a placebo effect as well, that it's then I've decided, no, I am taking care of myself. I'm doing this for myself. And it
don't knock the placebo effect. Sorry, this is how you use the word, placebo, and sometimes people think placebo means it's actually not really an effect at all. We in medicine utilize it a lot, and it doesn't mean it's a fraud or it's the fact that belief in potential benefits of things is a really powerful factor that influences the outcome. And that can be the same when you're thinking about, your life changes or whatever. Seeing that them as potentially positive enhances the chance they will be positive. It's not a force effect. It's part of the way life is. But you mentioned all sorts of things which may be beneficial. Exercise, we know, can have hugely beneficial effects for all sorts of reasons, probably partly neurochemical effects, but also just generally feeling better about yourself, your body, and so on. So I think, sleep, good sleep hygiene, and so on. These things undoubtedly are helpful, but having a positive attitude towards their likely benefits is also going to help.
Mm-hmm. Okay, and last question, what would you say to that attitude where some people are told suicide, it's terminal cancer or something, in depression can be a terminal thing and there's nothing that can be done, and I guess that's people are told that to help them cope in grieving.
Yes, that's an interesting question, because you reflected it partly from the point of view of others who maybe have lost someone through depression. I was thinking when you started to ask the question about the mindset of the person who's actually depressed.
Well, that's not helpful for them to be thinking like that.
No, I fully understand. But I've seen so many people who've been in absolute depths of despair, including friends, including indeed family, and have seen how things can shift and they come out of it, that I always feel positive about that people are, can improve. And I've just been helping a friend recently, who's gone through a bad depressive phase, and it's happened previously, and it's just been remarkable, the shift that's now happened, and that person is back to their normal self. That I would always try and retain positive expectations that things can improve, and try and convey that to people. It's difficult when someone's in the depths of despair, but fortunately, for pretty much everyone, things can improve.
And the pathway to recovery, I guess, is always very individual. Individual,
fluctuating, and sometimes surprising in the sense of how, well, in some cases, how rapidly things change, and in other cases, the extent of the improvement can be, just quite remarkable.
Mm-hmm. So I guess there's always reason to be hopeful, but at the same time, it's not to, if you have lost someone to suicide, it's not to feel like you should have done, something, like you could have done something, or because it's, I think
it's a natural instinct when a suicide of someone close happens, is to examine what one did in great detail. If only I'd have done this or hadn't done that. I mean, it maybe could be true, but so often we punish ourselves, thinking that maybe we could have done a lot more. So I think it's important to retain, I know it's easier to say, but to retain some sense of realism that, can't necessarily help everyone. It's not just one's own behaviour that's important. It's obviously the behaviour of the other people, but of course of the individual themselves, and who's depressed. So it's a very natural instinct to want to seek, to have thoughts of, gosh, if I'd have only done this, only done that. And I think it's important perhaps to stand back from sometimes,
Yeah, because I guess it's not like there's, even though we know, okay, there are things that do help with prevention, there are things that seem to, have a positive impact. It's not like there's a clear roadmap.
No, exactly. And if only you followed that roadmap, it would have worked out fine. No, I think that's a very useful way of thinking about it.
Mm. Yeah. Okay, we've gone.
Oh my gosh! I've just seen the time. Poor Joe.
Know, and we didn't get to cover half the things we're going to talk about. But last 3 quick questions. Is there a book that's had a big impact on your life?
Yes. Now I'm going to have to think of the title. It was a book I read very early on, right at the beginning of getting into psychiatry, which was about an examination of people who die by suicide, and this was actually before I think I got into even working in the field. And it examined, for example, Sylvia Plath's death and others. And then the author, whose name I'm desperately trying to think of, then in the last chapter talked about his own suicide attempt, which was really powerful. And that gave me some great insights into the thinking that goes on, part of the suicidal process.
You can message me later. I'll include the name at the bottom. Okay, how do you stay grounded?
Through having quite a lot of having good friends, but I think having a lot of interests outside work. And I mentioned right at the beginning about sport. I mean, that's really an important part of my life. Music, really important. Also, I find music so emotionally provoking, in positive ways, but I mean, not necessarily feeling good, but I quite like sad music that makes you feel the full range of emotions, and but that helps greatly. And gardening.
Great.
Literally grounded.
And what 3 words describe the best version of you?
Cheerful. I'd like to think empathic. And fun.
Great. Anything else before we wrap up?
No, that's good.